So last time we discussed the final, I think that was the last thing that's pretty much like brand new to step two. Things we probably never really heard of in step one, which were related to the accelerations and the decelerations that we see from the different tests we do on a fetus of a pregnant woman. Right? So first we saw the various decelerations that were occurring, where we had these decelerations, right? The heart rate was going down, and we saw the three different types that occurred and what they were associated to. Very important to make sure you understand this table over here, how it works, how you're supposed to read it, and what kind of case scenarios can occur that can lead to these etiologies. Keep in mind that the answer won't always be this etiology itself, but it could be something else that would cause this etiology to occur, right? So for example, we did one question where the patient had late decelerations, but the answer wasn't uteroplacental insufficiency. Keep in mind that you could have uteroplacental insufficiency even if you have uterine rupture, which was actually the answer to that question. Like for example, this one here, this question had the correct answer, uteroplacental insufficiency, which was a direct answer. But then we had, let me find the other one. This question right here, which was also showing late decelerations, but here the answer was uterine rupture, because uterine rupture can lead to uteroplacental insufficiency, right? So that kind of stuff. So very important to make sure you understand this table. And then in the last video, we did things that had accelerations, or at least they should have accelerations. Right? You should see two accelerations lasting at least 15 seconds over a 20-minute period. And we talked about how many times a mom should feel fetal movement, right? That in 2 hours there should be hopefully at least 10 fetal movements. So if you don't have those accelerations where now the heart rate goes up because you did some kind of stimulation, then that indicates that the baby is not responding adequately, and you have to continue up on that, follow up on that with like a BPP or a contraction stress test based off of what comorbidities exist, right? Because you can't do a contraction stress test, for example, for everyone, because if you cause a contraction stress test in someone who is at risk of preterm labor, you're actually going to end up causing preterm labor, right? Many case scenarios where you can't do it, and this question we did yesterday was an example of such a scenario where the mom had placenta previa. So if you do a contraction stress test on her, that's actually going to just cause that placenta to just rupture, and that's not going to be good. The baby can die. So stuff like that, very new things, never been discussed in step one. And now we're moving on to basically things that have been discussed in step one. So now it's not going to be anything completely brand new. Medical complications of pregnancy. So we have hyperemesis. We're going to see diabetes in pregnancy, pre-gestational diabetes, and then gestational and chronic hypertension, which will lead on to topics of preeclampsia and eclampsia, all of which are topics that have already been talked about at some point in step one. So these were things that were tested in step one as well. Hyperemesis gravidarum, persistent vomiting not related to other causes, acute starvation, usually large ketonuria and weight loss, usually at least a 5% drop from pre-pregnancy weight. Right now, that's really weird, because remember that pre-pregnancy weight, you're supposed to gain at least 25 pounds, maybe up to 35 pounds during the pregnancy. So if you have a drop from pre-pregnancy weight, then there's definitely a problem, right? Weight loss is not a typical thing in pregnancy. More common in first pregnancies, multiple gestations, and molar pregnancies. And most questions I've seen about hyperemesis gravidarum are about molar pregnancies, where you have excessively high ACG, right? So the real culprit of this morning sickness aspect of things is the beta ACG. There's also going to be high estradiol, which are implicated in its pathophysiology. Distinguished from morning sickness, which usually starts 4 to 7 weeks of pregnancy and resolves pretty much in the first trimester, right? Under 16 weeks. It's just a first trimester thing. It could occur throughout the pregnancy, but it wouldn't be an everyday thing. It would be something that may occur once a month after this, right? So it's not supposed to be something that frequent. Also distinguished from acid reflux, gastroenteritis, hyperthyroidism, and other neurologic conditions that could possibly cause you to vomit all the time, right? So when we did neuro, we saw that some of the neurological conditions that could cause vomiting are any tumors that are compressing on the chemoreceptor trigger zone, any electrolyte imbalances, any kind of elevated intracranial pressure from like things like pseudotumor cerebri, which are definitely going to be topics because these are all women with pregnancy questions, and pseudotumor cerebri was a common complication of obese women, right? So definitely an important list of differentials. Diagnosis is clinical, and the best initial test, as with anything with pregnant women, is to do an ultrasonography. Evaluate for trophoblastic disease or multiple gestation, which if you see. So let me see. Let me open step 1 book also. So if you suspect that the patient has a molar pregnancy, then you're looking for things related to molar pregnancies, which was often that storm appearance or all kinds of other things that we saw when we were looking at hydatid-form moles right here, right? So remember this image right here. So if you have a pregnant woman, you would see this in their fetal area when you check their uterus, and that's your honeycombed cluster of grapes or snowstorm appearance for the complete mole. And if it's a partial mole, then that's not so difficult to analyze either, because you're going to be told in the question you see fetal parts, right? So this again is the step 1 topic. So is everything else we're about to look at, like hypertension in pregnancy, diabetes in pregnancy. These are all topics coming from step 1. So we'll go back here as necessary to kind of make sure we have the revision. Most of these topics are actually discussed better in the step 1 book. So as I said before, electrolyte abnormalities, right? You can always get vomiting from electrolyte abnormalities, abnormal liver enzymes. You want to check if the patient is having maybe pancreatitis or some kind of hepatitis that's causing the vomiting. So that's where the amylase and lipase are also key, right, for the pancreatitis. Wernicke encephalopathy from B1 deficiency may be present in severe cases. Look for gait ataxia and oculomotor dysfunction. And then, of course, with that topic, they're also going to make you differentiate with the alcoholic aspect of things. Best initial test to test for hyperemesis gravidarum is dietary changes in doxylamine pyridoxine, right? So, best initial treatment, to treat hyperemesis gravidarum is a dietary change in doxylamine pyridoxine. If no response, discontinue this and add metoclopramide, promethazine, or prochlorperazine. So remember, metoclopramide was one of your antiemetics, right? So they're trying different things if the doxylamine pyridoxine didn't help. Further, add another antiemetic, ondansetron, if vomiting is not resolved. If dehydrated, of course, administer IV fluids, IV nutritional supplementation, and ondansetron IV is going to be the key terminator of all of that vomiting, right? But there really shouldn't be too much vomiting. It's very rare to actually even find a question in UWorld or AMBOSS where they have a question about a mom that is persistently vomiting. If they do make a question about the persistent vomiting, it would be a very easy question. You just have to make sure that you can actually distinguish it from these other things. So of course the question may mention things here and there that might sound like acid reflux, gastroenteritis, or any one of these other things. It's up to you to understand the key features of acid reflux and gastroenteritis and differentiate that from persistent vomiting. Always remember, by the way, that women who have acid reflux, or people that have acid reflux, often refer to it as just chest pain when it's not really chest pain, right? It's like heartburn. So if a mom comes in with persistent vomiting and says she has chest pain is a huge red flag, right? You see that and you immediately start evaluating, like, okay, whoa, do you have coronary artery disease? Are you about to have a heart attack? What's happening here? And then they might tell you in the question that ECG is completely normal, right? So you see how this is a sneaky way to tell you that she actually has acid reflux. If ECG is normal, she doesn't have any jugular venous pressure, distension, nothing's wrong with her heart sounds, then she doesn't have chest pain. It's not that she has angina that she's reporting acid reflux, and her persistent vomiting may be due to indigestion with the acid reflux and all of that stuff, right? So for her, the best treatment would not be, because your questions may get difficult when they ask you what's the next best step in management, and then they have all of these answer choices as treatments. So for a woman who is actually just having excessive vomiting due to reflux, the best treatment would be dietary changes and omeprazole, right? Maybe you need her to stop eating certain kinds of foods. Like in my culture, one of the major issues with the Indian, Pakistani, Bangladeshi culture of pregnant women is that eating spicy foods often doesn't really work out too well for a pregnant woman, right? So you got to be very careful with that. Other things include, if you have a culture where maybe the food is often too salty, like for example, in many of the Chinese cultures, Chinese foods in general tend to be excessively salty. That can lead to excessive water retention and more vomiting and other things in pregnant women as well. So all kinds of things like that for you to evaluate. Just make sure you can actually differentiate and figure out that it is just persistent vomiting unrelated to anything else, right? Otherwise, if it's related to anything else, that's also easy. You just need to solve that other thing that it's related to, right? If it's acid reflux, as I said, omeprazole, dietary changes. Gastroenteritis, dietary changes. Hyperthyroidism, of course, get them started on the propylthiouracil, right? And then neurologic conditions, well, whatever is happening in the brain, you got to figure it out first, check the brain, and then evaluate and fix. Next question, diabetes in pregnancy, for which we have this practice question over here. So diabetes in pregnancy is extremely common, especially in America. Um, Oftentimes what happens is you might have a patient who was at the verge of becoming diabetic, and then they got pregnant, and now they're full-blown diabetic, right? And then other times you might have a patient who was far from ever being diabetic, and just during the pregnancy they became diabetic, and usually after the delivery the diabetes goes away, right? So diabetes in pregnancy is divided into two categories: gestational diabetes and pre-gestational diabetes. Gestational diabetes is onset that occurs during the pregnancy. Pre-gestational is before the pregnancy. If the woman has risk factors for diabetes, screen with fasting glucose or hemoglobin A1C, BMI more than 25, first degree relative with diabetes, high risk ethnicity like African American, Asian, pretty much everyone except Caucasian. PCOS, definitely a huge scenario for diabetes. Prior delivery of a baby that was more than 9 pounds, right? If she had a prior delivery that had a big baby, then that's a sign that the baby became big, probably because of excess insulin, right? Or if she previously was diagnosed with gestational diabetes, hypertension, or if she's on treatment for hypertension, any hemoglobin A1C that was pre-diabetic, right, 5.7, and then HDL levels being too low, right? So all kinds of things to look at. Pretty much this entire list of things is just anyone that's at risk of diabetes in general, right? So gestational diabetes first. This one, the one that occurs during the pregnancy. Carbohydrate intolerance of variable severity that is first diagnosed during pregnancy. Occurs in 3 to 5% of all pregnancies and is usually diagnosed in the third trimester. Nothing to worry about. You just deal with it. But the first thing is to actually identify it. Typically asymptomatic, may present with edema, polyhydramnios, or a large for gestational age infant. And step two loves throwing questions in where they might give you a growth chart, and we're going to see some of these as we go on, especially in neuro questions. They throw in a growth chart, and then if you've never seen a growth chart, let me actually find it, show it to you real quick. I think I put most of them in the pediatric chapter, because that's kind of what growth is more related to. So you'll get things like this. So I have one of these too. I saved mine from when I was very little. I might actually have it right here. I'm not sure. Yeah, I think so. No, that's not it. Yeah, if you've never seen one, it's definitely worth seeing it. And I know I have it somewhere. I saved mine from when I was doing my pediatric visits. My mom gave it to me, and I was like, "Oh yeah, I'll hold on to this. It's nice." They don't really do it the same way anymore, so it's worth saving. Oh, here we go. So you can see here in America, one of the things that occur with pediatric development. So this is like extremely old. Like you can see, there's a chart like this, right? And it has lines on it, very much like the line in the video right now. So those watching the recording won't be able to see the actual chart I'm holding, but I'll make a video where I actually post about it a little. And what you see basically is that these lines are telling you the upper and lower limits of what would be in this specific graph considered macro and microcephaly, big head size, small head size, right? On the one I'm looking at right now, there's a chart for boys' weight for age, boy's height for age, and it also has a breakdown of things I should be able to do as the age is occurring. So on the x-axis, on the bottom, the horizontal axis, there's age, and on the y-axis, there's inches for the height that I should be achieving, or on the other one, there's pounds for the weight I should be achieving. And then if you look closely at the image at the top, you can see like it's a list of things I should be able to do as age occurs, right? So that's what they're showing here. This was a very common thing initially, and moms would take this home with them and bring them back on consecutive visits. On the other side, there's like screening tests I had to get done, like hemoglobin electrophoresis and tuberculin tests. And there's a calendar for healthcare visits. And one page that has unfortunately ripped out of here is a list of vaccinations I had to get done. Right? So with all the dates on it. So this used to be a thing. This definitely used to be a thing big time. I have my NYC Department of Health ID in here, an MR number and whatnot. And all of this is not really done the same way anymore because now we have better computer systems that keep all the data safe for us, right? So that's one of the key things. Now these tables, although not done as much in the same way with an actual yellow card you take home, these tables are still a reality, and they are all there in the computers for all kids that are born and managed. And doctors save all of this in their online profiles, so they can give you something like this. And what often happens is it'll have dots plotting out where your growth is. So for example, on the 2 month visit, your growth might have been over here, right? On the 8 month visit, your growth might have been, now depending on what the pathology is, let's say we have a big baby, then your growth, well, you would come back every 2 months essentially in the beginning, so your growth might have been like up here, and then boom, now you're approaching macrocephaly, and then they'll start plotting dots like that are right up there. That's literally the 98th percentile, and 98th percentile is macrocephaly, right? You're basically bigger than 98% of people, right? So that's a big baby. Similarly, they could also plot dots on the lower axis of things every 2 months, and then if you're seeing that, that's a baby that's too small for its age, and that's also of course a problem, right? So all dots should fall within the middle area between 90 to 10, and that's kind of what always occurs unless there's some kind of pathology, right? So you're going to see all kinds of them. There's also charts like this for the age and growth in girls, right? And you're not going to have these labels there. You're going to have to figure those labels out based off of age. So you can see here there was a question right here that we'll see when we get to pediatrics, where they've done this, right? They've got the plotting here, and you can see clearly there's a problem right here. That's not a good plot. See, everything was going just fine, and then you could see that in the beginning this child was about the 50th percentile, right? It was tracking along the 50th percentile, which is great. You're basically average. Your growth is just like everyone else, right? About your growth is like about 50% of people, which is perfectly fine. But then out of nowhere there's a huge jump to the 97, 98th percentile, which is definitely indicative of issues, and the answer here was to do a CT scan of the brain, right? Because that's not good. So all kinds of things like that would get tested. Now going back to where we were with this topic of gestational diabetes, you could get that same growth chart where they'll show you that the baby is, and instead of head size, they could do head size too, but instead of head size they might be talking about the weight across ages, like my yellow card was showing, right? So if the weight is too much, or if the weight is on the higher end of the percentiles, then that's indicative of how the mom may have diabetes. Moving on, what else to say? So the presentation is never going to be anything crazy obvious, so it's very important for you to figure it out yourself. Diagnosis is now this is actually a question. They'll tell you what test should you order to figure out what's happening, and they'll have all the different tests that you can possibly do for diabetes. Best initial test is 1 hour 50-gram glucose challenge test. This is the answer you should always pick. Keep in mind, we are trying to diagnose gestational diabetes. Do not pick to do a fasting glucose. You can't get a pregnant mom to come to the clinic fasting, right? But you could get a pregnant mom to drink 50-gram glucose, any like little apple juice or something like that is usually there, and then see how her body responded. Venous plasma glucose is measured 1 hour later, performed at 24 to 28 weeks gestation. Values over 140 are considered abnormal, right? Confirm this now. So you see the initial test was to do a 50-gram glucose challenge test. Confirm this now with an oral 3-hour 100 gram glucose tolerance test, right? And showing any of the two following. So usually not going to be fasting, but generally speaking, you're going to have sugar levels that are higher than what you would expect it to be. That's it. Right? So if this test was positive, this was the screening test. If it's positive, then you do this, which is your confirmatory test. So both are basically the tolerance test, 50 grams and then 100 grams, right? You never pick any of the other answer choices that say do fasting glucose, do glucose blood tests, or any of these, excuse me, any of these other things. You would do the glucose blood test, but after a 50-gram glucose challenge test, not just take her blood from wherever she is, right? So very important to make sure it's a very simple topic. You give the mom glucose and see how her body responds to it. That's how you're checking a pregnant woman for diabetes, not in any other way that you would use on non-pregnant people. Now for treatment, you have to treat both the mom and the fetus, obviously. So the mom, best initial treatment is just the diet, regular exercise, and strict glucose monitoring, which of course fails, right? This never works. You would tell a mom all she needs to do, even if she's pregnant, it doesn't mean that she's gonna go do what she needs to do for her own well-being, right? So then, of course, oftentimes what ends up happening is we have to end up adding insulin. So although they've written this as an answer choice here, this is not the answer choice you pick. Very rarely, I've never seen a question where this was the correct answer. Tell her to change her diet. No, she's not going to change her diet. She knew when she was eating what she was eating that it wasn't the best for her in her pregnant state. Okay, she's not going to change that. And other comorbidities that the pregnant mom might have will further tell you that she doesn't really take care of herself. You know, if they tell you in the question that she's very overweight, if they tell you in the question that she smokes and she's been trying to cut back even though she's pregnant, remember that cutting back when you're pregnant doesn't help. You might as well keep smoking all you want to. So adding the insulin often ends up being the important thing to do, right? So add insulin if dietary control is insufficient, and it will be insufficient. So add the insulin. Tight maternal glucose control improves outcomes, right? So there should be fasting glucose under 95, and if after eating, sugar levels should be under 140. Right, 2 hours later it should be under 120, which all indicates that insulin is working and glucose is being shifted into cells. Okay, if it's not happening, then all that glucose is going to float around and go to the baby. Eventually, the baby is going to end up really making its own insulin, which is an anabolic hormone, so the baby ends up becoming really big. Give intrapartum insulin and dextrose to maintain tight control during delivery as well. Fetus obtain periodic ultrasonography and non-stress tests to assess fetal growth and well-being. It is recommended to induce labor at 39 to 40 weeks gestation in patients with gestational diabetes controlled on insulin or an oral hypoglycemic agent like any metformin or whatever. So all in all, there's a lot happening here that you can get tested on. Okay, there's a lot happening you can get tested on. You can get questions about anything based off of what you should do, not only to diagnose but also to treat the mom and treat the fetus. Complications: more than 50% of patients go on to develop glucose intolerance and or type 2 diabetes later in life, especially if they didn't manage it very well when it was first diagnosed right here. At 6 to 12 weeks postpartum, screen for diabetes with a 75-gram 2-hour GTT and repeat testing every 3 years if normal results occur. Right. So even after you're doing a glucose tolerance test, not anything else, right? You're just giving glucose and seeing how the mom is responding. Now that she's delivered, it's been 2 months since she delivered. Things should, or 3 months since she delivered, it should be back to normal now. Her body should be managing everything just fine. If not, then she probably has diabetes now, and you have to put her on a diabetic regimen. So that was gestational diabetes. Now let's take a look at pre-gestational. So being diabetic before you're pregnant. Observed in 1% of all pregnancies, insulin requirements may increase as much as 3-fold during the pregnancy. Poorly controlled diabetes is associated with an increased risk of congenital malformations, fetal loss, and maternal fetal morbidity during labor and delivery. Treatment for the mom, renal. So here they're telling you both things that you're like everything you needed to do basically for any woman that's pregnant. And diabetic, so it's renal, ophthalmologic, neural tube, and cardiac evaluations, because these are all things that get messed up by diabetes, right? You're gonna have too much sugar, that's gonna mess. Remember that diabetes is an inflammatory disease, just like atherosclerosis, right? Atherosclerosis is also inflammatory. So if you have both diabetes and bad lipid control, that's double inflammatory disease. So diabetes, the all that diabetes is going to cause inflammation of the renal artery, which is a singular renal artery, the ophthalmologic artery that goes to the eye, which is also a singular artery, the neural tube, because you're going to be damaging all the blood vessels in the brain, and cardiac evaluation, because you have your singular left and right coronary arteries, which also get messed up, right? So you need to assess all these end organ damages. You can look for creatinine here. You can look for any kind of visual disturbances that are not related to the muscles of the eye. So it shouldn't be like double vision or something, but more so something along the lines of glaucoma. Neural tube defects. Now these neural tube, what they're talking about here is in the mom, not a neural tube defect of the fetus, but more so some kind of neurological deficit, not being able to feel your feet, for example, right? This is why we check diabetes patients' foot to see if they have a diabetic foot ulcer. So sensory losses, that's usually the first thing that occurs. And then of course any cardiac evaluation would mainly involve if they have any chest pain at all, right, or palpitations. Best initial treatment is of course things that they'll never do: lifestyle modification with diet and exercise. So that'll never happen. So you go ahead and add insulin therapy if poor response. What you'll see in most OBGYN clinics is that physicians tend to have a pamphlet they can give to the mom to take home, which is telling them lifestyle modifications they can do, what kind of very simple workouts they can do during their pregnancy, and what kind of foods to definitely avoid, right? Any workout is more than no workout. But even then, this topic of lifestyle modification with diet and exercise clashes heavily with many cultures. I could speak about my own Indian cultures back in India, especially in the more illiterate areas, but even in the very literate areas, it is taboo to diet or exercise as a pregnant woman, which then, of course, explains why diabetes is so rampant in the Indian culture, right? So when a woman is pregnant, it does not mean that she is the most weak person on earth and should just sit there and have the most royal treatment for life, right? That's not the point there. Of course, they should be treated royally as a pregnant woman, yes, but you need to diet and exercise, right? And you don't become a king where you're just eating and sitting there all day. So that's not going to be good for either the mom or the fetus, and that's usually what occurs. So when a doctor tries to advise a patient that you should diet and exercise, they'll look at you weird, right? So you got to be very careful with that. It's never the answer choice. I have yet to, if you ever see a question where this was the answer for a pregnant woman, that you're supposed to advise them lifestyle modification with diet and exercise, I'd love to see that, because it's I haven't seen that yet. It's always adding some kind of therapy, because this they'll take their insulin, but they're not going to work out, right? And then strict glucose control is also something they won't really be able to do. But again, if they're being, if they're at least doing their bare minimum, which is coming in for regular checkups, then I guess we just have to be grateful for just that much. Be grateful for that much and save the baby by letting the mom know that her sugar is too high. Another thing that happens during pregnancy is people come by to congratulate you, and oftentimes in the Indian culture, which also includes somewhat the Pakistani and Bangladeshi culture, we come with sweets, all kinds of sweets that are super sugary, and of course the mom eats it. So it's never good. Delivery and postpartum maintenance. So maintain normal glycemia as much as you can during the labor with an IV insulin drip and hourly glucose measurements. Consider delivery in the setting of poor maternal glucose control, preeclampsia, macrosomia, or evidence of fetal lung maturity. Consider C-section delivery in the setting of an estimated fetal weight that's too big, a baby that's too big. Encourage breastfeeding with an appropriate increase in caloric intake, right? So in America, we have heavy screening that we watch for everything, and we make sure we take every single precaution possible, which is partly why medical treatment in America is extremely expensive, right? That some would say it's overpriced, and it probably is, because the other reason it's expensive is because it's all a business and it's kind of not really controlled by the government. But if we look at treatment in Canada, I was discussing with one of my Canadian friends that treatment in Canada, although free, is also very lax. He was telling me how in all his rotations over there, he saw that treatment was very rarely preventative. Everything is free, so if something's wrong, you come in, you take your medication, you go home, and you get better. But very rarely is ever there any kind of long discussion where the physician sits with the patient, has a talk about all the things that are happening, what's wrong with them, getting very comfortable and personal with the patient. These are not things that are apparently common in Canadian clinics, and these are the things that make us special. So we need to watch everything. We need to think of every single possibility that can occur, and we need to watch out for every possible outcome before the outcome becomes a reality. So you see how everything right now was basically things we were doing for the mom. And then there's also the fetal aspect, right? We have the quad screen, the ultrasonography to determine fetal age and growth. We have to make sure that age and growth match, as I was showing in the yellow card, right? But the yellow card I was showing was for after I was born. This is happening for things that are before the baby is born. And if the baby is far bigger than the age, then you need to make sure that you calculated the age correctly. And if you did calculate the age correctly, then the baby must just be too big. At which point, if the baby is too big, you need to do C-section, right? Fetal echo to evaluate for cardiac anomalies. Closed fetal surveillance. Admit if maternal DM has been poorly controlled. And serial ultrasonograms for fetal growth, right? So you have to do all of this to make sure that the baby is developing fine, right? Otherwise, as we learned in step 1, all that free sugar in the mom floats into the baby, and the baby can make its own insulin after a certain point. And all that excessive insulin is going to make the baby very big. So let's take a look at this question right here. We have a 5-hour-old boy, so baby was just born, evaluated in the nursery for minimal right arm movement. He was born at 39 weeks gestation to a 37-year-old multigravida via vaginal delivery, complicated by difficulty extracting the shoulders. So just extracting the shoulders, as you'll see in pediatrics, is a scary thing, especially if the baby is big, because that leads to shoulder dystocia. And also, if you pull on the shoulder in a weird way, you can rip the brachial plexus of the baby as well. And in this case scenario, with the baby not being able to move the right arm, it is very much possible they might have harmed the brachial plexus. Review of medical records reveals a maternal history of hypertension and recreational marijuana use. Of course. The mom missed most of her prenatal appointments. The patient's birth weight is 4.5 kilograms. So that's almost a 10-pound baby. That's big. Right? So this is a terrible mom, first of all, right? Didn't really come in for her regular visits, was probably using marijuana even during the pregnancy, and obviously didn't really manage her diabetes very well because it's clearly taking toll. Vital signs are normal. Exam shows a plethoric infant with crepitus and irregularity over the right clavicle. Moral reflex is absent on the right extremity. Bilateral biceps and grasp reflexes are intact and symmetric. So they made this a really easy question by not really asking you what exactly is wrong with the baby. They just wanted to know what risk factor predisposed the infant to this issue, and it was fetal hyperglycemia. All right, so table below is provided, and we'll take a look at it. It's a workflow. This neonate's birth weight is consistent with macrosomia, more than 8 pounds, more than 4 kilograms, and his physical exam findings reflect complications of shoulder dystocia. Fetal hyperglycemia due to untreated maternal diabetes is the most common underlying risk factor. Mild maternal insulin resistance is a physiologic process of pregnancy that facilitates the diffusion of glucose across the placenta for fetal growth. Right, and that makes sense, right? So the mom, a pregnant woman, initially develops a little bit of insulin resistance, just so all the sugar she eats doesn't immediately get absorbed by her thanks to her own insulin. So some of the sugar should be floating around in the blood so that it can make it to the placenta and get to the baby. That's okay. But this mild aspect often gets ruined and becomes more than mild, especially depending on how much sugar the mom is even taking. Because if you as a pregnant woman have naturally developed a little bit of insulin resistance, then it would really suck if you followed the Indian culture and went ahead and ate double sugar, because now you're eating sugar for yourself and your baby. Because not only did you already have insulin resistance so that some of the sugar you ate made it to the baby, but now you're also eating double sugar, which of course adds on to the formation of diabetes. Right? Keep in mind also that during the pregnancy you're supposed to gain at least 25 pounds. So you're also putting on weight, which is more adipose, adding towards more insulin resistance, and hence how gestational diabetes develops, right? So very important to teach mothers this thing, which is what doctors fail at, that you need to let the mom know that during pregnancy, your body naturally doesn't absorb all the sugar you eat, so that some of the sugar will stay in the blood and go to the baby. So you don't need to eat extra sugar, because you would need to eat extra sugar if all the sugar you ate was being absorbed by your own body, but that's not what's happening, right? So once you explain that to a mom, they're often better equipped and more understanding of the fact that they don't need to be eating double, right? Eating for two is a concept that is common in many cultures, where the elder people will come tell you, oh, you need to eat for two now. So that leads to double the problem, and you actually mess up both people, the fetus and the mom. However, excessive maternal hyperglycemia results in fetal hyperglycemia, which increases fetal pancreatic insulin secretion, causing fetal hyperinsulin. And insulin is anabolic. Excessive production of fetal insulin, an anabolic hormone, leads to macrosomia with disproportionate growth and fat accumulation over the shoulders and abdomen. As a result, the shoulders can become impacted in the maternal pelvis, resulting in shoulder dystocia. Of course, if she was coming for regular checkups, we would know that the baby is big. We would try to manage her sugar better, get her fetus to definitely be less hyperinsulinemic, and then if the baby was too big, we would make sure to not do vaginal delivery. Right? We would just do C-section, because now look, vaginal delivery is done and the baby is not moving correctly. Potential complications of this include clavicle fracture, brachial nerve palsy, perinatal asphyxia, and hypoxic encephalopathy. Maternal hyperglycemia can also lead to neonatal polycythemia and plethora, as well as postnatal hypoglycemia. Fetal hyperglycemia and hyperinsulinemia likely contributed to this macrosomia, plethora, and shoulder dystocia with resulting clavicle fracture, which is why the baby has crepitus and asymmetric motor reflex. Right? So the crepitus was told, the absent motor reflex was told, which is what gave away the fact that the baby definitely has some kind of injury. Right? Crepitus is air under your skin. So you hear like a crunching sound when you palpate, and we've seen that in adults in questions before, where after a car accident it can happen, but not in babies. Right? So very important thing to manage. Here we're looking at the workflow. So if you have a mom and she has maternal hypoglycemia, then is it the first trimester? If it is the first trimester, you need to evaluate for a lot of things in the fetus, because the baby is developing very rapidly in the first trimester. Right? You're forming all the organs, you're developing the whole layout, everything is being formed, and imagine all that hyperglycemia is going to be causing non-enzymatic glycation and inflammation in a developing baby. So you need to check for all of this. If there's maternal hyperglycemia in the second and third trimester, then you need to check the baby to see if the fetus has hyperinsulin. Right? If the baby has too much insulin, then that's going to lead to all kinds of complications. One, elevated metabolic demand, which leads to fetal hypoxemia, more red blood cell formation, and then boom, you get polycythemia. Possible answer choice. You're going to get organomegaly, because insulin makes everything bigger. You're going to get neonatal hypoglycemia, because the baby's going to make a lot of insulin, but when the baby is born, the baby is still going to have high insulin, but the sugar intake will stop, because the sugar intake wasn't the baby eating sugar, the sugar intake was the mom eating sugar, but now the baby came out of the mom. Right, so very important answer choice to make sure you understand. Do not pick neonatal hyperglycemia, right? Depending on what they ask. Fetal hyperglycemia, yes. As a fetus, there's hyperglycemia because the baby is getting excess sugar due to the mom eating excess sugar. But neonatal, meaning that you're born now, neonatal hypoglycemia. When you're born, you stopped eating all that sugar because you're not inside the mom anymore, and the babies don't eat a lot of sugar. Newborns can't eat whatever they want to. They're fed what they're given by the hospital. So this baby is not going to have high sugar, but then the high insulin is still there. So then that ends up causing neonatal hypoglycemia. For these babies, what you actually end up having to do is just fix the hypoglycemia by giving them sugar. Now that they're out of the mom, they're savable, and you can determine their outcome. And then of course there's going to be macrosomia because it makes everything bigger, so the head becomes big. And if that occurs, you do not do vaginal delivery, right? Because you want to avoid shoulder dystocia, which is what our question currently was about. Right? So many complications, very important to understand them, very important to see why it is the way it is. And then what we just looked at, right? The two-step approach for screening and diagnosing gestational diabetes was straight up doing a glucose tolerance test. You never ask a mom, a pregnant woman, to come fasting. Right? That's not gonna happen. Right? From here on, I've got a couple notes. So let's see. During the third trimester of pregnancy, the fetus has an increased demand for glucose and other nutrients due to accelerated growth and increased metabolic needs. Physiological adaptations of pregnancy include pancreatic beta cell hyperplasia, increased insulin secretion, and increased peripheral insulin resistance, which are the things that we just talked about a little while ago, that moms do this naturally so that the more sugar can go to the baby. HPL, human placental lactogen, a placental somatomamotropin, has more production in the third trimester, resulting in pancreatic beta cell hyperplasia and increased insulin resistance. Screening for gestational diabetes is with 1 hour glucose challenge test, and diagnosis is with a 3-hour glucose challenge test. Super straightforward. Right? But the HPL is one thing you do need to keep in mind. This was a pathophysiological thing that was definitely tested more in step 1, human placental lactogen. If we actually go back and see, we can find it real quick. Lactogen. So this table here is showing you things that a pregnant woman makes. Right? You can see how in the third trimester, the green line is the highest line, human placental lactogen. Right? There's also going to be more prolactin, more progesterone. Estrogen is always increasing, but it's not supposed to be that high. And ACG plummets down after 14 weeks because now the placenta is taking care of everything. Right? So you still need to know these things. If you forgot any of these stuff, from back in step 1, you do need to make sure you go back and revisit it. With the different hormones, remember that ACG had an identical alpha subunit, just like LH, FSH, and TSH. So ACG causes many other effects simply by mimicking these other guys. So states of high ACG can cause hyperthyroidism. So you need to make sure it's not gestational hyperthyroidism. You need to make sure it is or differentiate between gestational hyperthyroidism versus not real, like Graves' disease, right? It's not Graves' disease. It's just gestational hyperthyroidism because of ACG mimicking TSH, right? But the beta subunit is what's unique, which is why we always check for beta ACG. Right? If you were checking for alpha ACG, you would also be seeing TSH, FSH, and LH, and then that's not going to give you the correct answer. HPL, this is something that's made by the syncytial trophoblast of the placenta, and it just stimulates more insulin production, right? Causing more insulin resistance. Can add on to gestational diabetes, but again, this is why you exercise and diet correctly when you're pregnant. Right? So that being said, next topic is your gestational and chronic hypertension. So gestational hypertension is idiopathic hypertension that's occurring for no real reason without significant proteinuria. Proteinuria should be under 300 milligrams per liter. Develops at over 20 weeks gestation, and as many as 25% of patients may go on to develop preeclampsia. Must normalize within 12 weeks after pregnancy. Chronic hypertension presents before conception or at under 20 weeks gestation. If increased blood pressure persists for more than 12 weeks postpartum, then that's also bad, and up to 1/3 of patients may develop superimposed preeclampsia. So here they're differentiating the terminology of what is gestational hypertension and what is chronic hypertension. The key landmark being that gestational is after 20 weeks and chronic hypertension is before 20 weeks. The 20-week period, which is half the pregnancy, is a key point. We talked about this already. Complications of pre-gestational diabetes. And then this, I believe, was this is actually a question where it has one of the answer choices, polycythemia, right from here. Right, so you see how this question had this answer choice, polycythemia. So this question here is actually showing you that. We'll come back to that. Of course, monitor blood pressure closely. Best initial treatment is with appropriate antihypertensive, which of course that means that you have to now go back to cardiovascular pharmacology. And when you do that, you see the main medications you use to manage hypertension in pregnancy: hydralazine, labetalol, methodopa, and nifedipine. Most likely being labetalol. So most often used is nifedipine, and the go-to beta blocker is labetalol, since it can be given IV and it has alpha 1, beta 1, and beta 2 adrenergic antagonist activity, which will then allow you to preserve blood flow from the uterine arteries to the placenta. So we love labetalol. It's the easiest thing to give. The alpha 1 and beta 1 combination substantially decreases vascular smooth muscle tone. Hydralazine can increase fluid retention, so methyl-dopa is more preferred since it can bind to alpha 2 receptors at the presynaptic membrane. And this agonist activity drops norepinephrine release, thereby lowering blood pressure. Right, so a lot to know here, but you definitely want to make sure you know these 4 medications very well. I mean, you had to know them very well for step 1, so definitely make sure you revise that, right? And that's what we're going to see here as well. So treat with appropriate hypertensive methyl-dopa, labetalol, and nifedipine. Right? If systolic blood pressure is more than 160, which is terrible, or diastolic blood pressure is more than 110, which is also terrible, this is a hypertensive crisis. Treat with labetalol, hydralazine, or nifedipine because of short onset of action. Do not give ACE inhibitors or diuretics. You don't treat this the same way you would treat any other adult. Right? So contraindicated. This table here is telling you everything you're supposed to use. Right? Beta blocker, calcium channel blocker, hydralazine, methyl-dopa, like we just saw in the other page in step 1. Second line include clonidine and thiazide diuretics. So this is an alpha medication, and then this is of course a diuretic. Do not give what you would give to every other adult that's got hypertension, ACE inhibitors. Remember, ACE inhibitors are actually teratogenic. They can actually cause issues in the mom as well. Here they tell you ACE inhibitors are known to lead to uterine ischemia. So they must have found this out by actually giving ACE inhibitors to moms and then causing uterine ischemia. Diuretics can aggravate low plasma volume to the point of uterine ischemia. So keep in mind that anytime you ever give a patient diuretics, especially aggressive diuretics, then you need to understand that you might actually cause fluid depletion in that patient, and that can actually lead to more issues, right? So now the patient is in a sense going to be dehydrated, right? So oftentimes when you do aggressive diuretic use for non-pregnant patients, aggressive diuretic use, you also have to give them saline and stuff. You also have to fill them with fluid as well, because you're trying to get the diuresis to occur from one location, but you're also putting fluid in another location. It's not like you're emptying and filling the same area. Aggressive diuretic use can lead to renal damage because you're going to have no fluid. So dehydration always causes renal damage and all kinds of other issues. But definitely don't want to use any of these medications in a pregnant woman. It doesn't work too well for them. Complications are going to be similar to what's going to happen in preeclampsia, so we're going to see that now. Preeclampsia is a really big problem. New onset hypertension and proteinuria, right, occurring at more than 20 weeks gestation. So how do we differentiate preeclampsia from gestational hypertension? Right now I underlined 2 things right here, which was the difference between gestational hypertension and chronic hypertension, whether or not it occurred before or after 20 weeks. After 20 weeks, it was gestational. Now, how do you differentiate gestational hypertension from preeclampsia? That's by the proteinuria. Right, so you can see how in gestational hypertension, there's less than 300 milligrams per liter of proteinuria. In preeclampsia, there's more than 300 milligrams of proteinuria. New onset hypertension and proteinuria occurring at more than 20 weeks gestation. Or new onset hypertension with new onset of any of the following issues: platelet count that's less than 100, serum creatinine that's starting to become problematic, liver enzymes that are more than twice the upper limit, pulmonary edema, and cerebral or visual symptoms, which are causing, of course, end organ damage, right? So all of these together will tell you that there's a problem here. HELP syndrome is another thing. This stands for stuff. So HELP syndrome is a variant of preeclampsia with a poor prognosis, really bad. Consists of hemolytic anemia, that's the H, hemolysis. EL is elevated liver enzymes, and then LP is low platelets, right? So that's what the HELP means, right? They got the mnemonic right here. Hemolysis, elevated liver, low platelets, right? The etiology is unknown, but clinical manifestations are explained by vasospasm leading to distension of hepatic capsule, hemorrhage, and organ necrosis. Risk factors include nulliparity, African American, ethnicity, extremes of age, too young or too old, multiple gestation, molar pregnancy, and a bunch of other things that are not really things that you would want to occur. This age thing is the only thing that's kind of unfortunate. There are a bunch of people out there that get pregnant before age 20 and over age 35. More commonly, there's a lot of people, especially in today's era, that get pregnant after age 35 because everyone's independent and well off and happy. Don't need to rush into getting pregnant, right? So then this isn't really like true, but on step one, it's a reality. So if you have a patient who's over age 36, 37, like that, you need to kind of put that in a different category in your mind when you're reading the question. Now, treatment, delivery of the fetus. That's the only cure for preeclampsia. That proteinuria is not going to get fixed by giving labetalol and stuff like that. Close to term or worsening preeclampsia, induce delivery with IV oxytocin, prostaglandins, or even amniotomy, but amniotomy is a little dangerous. Deliver no later than 37 weeks. Far from term. If the baby is still far from term, but the preeclampsia is becoming a problem, then treat with modified bed rest and expectant management. Prevent intrapartum seizures with continuous magnesium sulfate drip. Watch for signs of magnesium toxicity, which I had a question on, so I put this here. Continue seizure prophylaxis for 24 hours postpartum, and treat magnesium toxicity with IV calcium gluconate. Very important to remember that. Right, magnesium acts as a calcium channel blocker on the CNS to raise seizure threshold, thereby preventing seizures from occurring. Toxicity can occur. Initially, you may note an absence of detentor reflexes. Further toxicity is rare in patients with normal renal function. If the patient has decreased urine output, there will be decreased urinary excretion of magnesium. The areflexia may then progress to respiratory depression and cardiac arrest. So immediate cessation of magnesium is needed. Start calcium gluconate to reverse neuromuscular paralysis, stabilize cardiac membranes, and prevent cardiac arrest. So magnesium, you have to be very careful when you do start it on anyone for preeclampsia because it's something that can have many side effects. In step one, this was not really taught much. In step one, this was mentioned that when you give magnesium, it could lead to a toxicity, so you treat it with calcium gluconate. But they didn't explain what would occur. And in fact, even in the book right here, well, actually here they've done a good job. They did list it out for you. Loss of detentor reflexes, respiratory paralysis, and coma, which are all things you definitely don't want in a pregnant mom. Right? But in step one, this wasn't mentioned. So key thing to keep in mind here, it's a new topic for the most part. So now we can go, let me see just real quick. Presentation of preeclampsia, eclampsia, UTIs. Okay. So now actually we can just go back and look at some of the questions we have real quick. So starting from right here, we have a 38-year-old woman, G1P0, so it's her first pregnancy, but notice the age, more than 35. Comes to the office for her first prenatal visit. Her last menstrual period was 12 weeks ago, so she's pregnant. She has had nausea and vomiting occasionally over the past few weeks, but no other symptoms. She has not seen a doctor in years, but has no known medical conditions and takes no medications. Well, she hasn't seen a doctor. She may have known medical conditions that we just haven't really discovered yet. Her blood pressure, this I believe is supposed to be 140 over 96, and 138 over 92 on repeat measurement 15 minutes later. Physical exam shows an anxious woman with mild bilateral ankle edema and enlarged uterus. Ultrasound confirms an intrauterine pregnancy consistent with the dates, consistent with her 12 weeks ago last menstrual period. A urinalysis dipstick is negative for protein and glucose. She returns to the office for a blood pressure measurement a week later, and her blood pressure is still high. So now, notice what's happening, right? There's a time period being given. So these the two things here, the thing I circled and the thing I underlined. There's a time period being given, which we are seeing that she's under 20 weeks, right? So she's under 20 weeks is not preeclampsia. And if she's under 20 weeks, it's not gestational hypertension, right? It's definitely not just the underlying portion was what differentiated gestational hypertension from chronic hypertension. So if it's under 20 weeks, this is definitely just someone with chronic hypertension, which obviously wasn't diagnosed because she hasn't seen a doctor for years, right? This would also be a person we would classify as a terrible mom, because if you're trying to get pregnant, you're supposed to go see a doctor before you try to get pregnant, right? Get everything checked up, make sure you're ready to get pregnant, everything's good, start folate, etc., etc. On top of that, they also did the protein check, and there was no proteinuria. So the amount of proteinuria was also critical for determining many things. But for her, now they're going to ask you what's the most likely diagnosis, and look at that. Chronic hypertension was the obvious correct answer, but 25% of people who didn't remember the key differences also picked gestational hypertension because she's pregnant. But gestational anything is after 20 weeks, right? It's gestational hypertension if it's after 20 weeks. Preeclampsia is also after 20 weeks, but preeclampsia would have a lot of proteinuria, which she doesn't have, right? So that's all they're explaining here. So the time differences and understanding the criteria you need to meet for certain diagnoses is critical here. And then part 2 says she is at greatest risk for which complication? Well, if she has chronic hypertension, she's chronically squeezing her blood vessels, so not enough blood is going to be making it to the baby, so it's just going to be something about the baby not growing well. Here the answer was preterm labor. Hypertension is associated with both fetal and maternal morbidity. The risk for preterm labor and other complications may be linked to the increased resistance and arterial stiffness leading to placental dysfunction, right? Not enough blood going to the placenta, baby's not going to grow all the way, and you're going to have early preterm labor. In addition, expedited preterm delivery may be indicated for treatment of an unstable maternal or fetal complication. So maybe delivering earlier oftentimes is what you need to do. So it's going to be preterm labor either way. Either she's going to go into labor herself naturally, too early, or you're going to have to push early labor because things are going bad due to the unmanaged hypertension. So that's your breakdown. This table here does a full breakdown of what's happening. So chronic hypertension, blood pressure that's higher than normal prior to conception or 20 weeks gestation. Gestational hypertension is after 20 weeks gestation, but no proteinuria or end organ damage. Preeclampsia is after 20 weeks gestation and has proteinuria or end organ damage. Eclampsia is your addition of seizures. And then there's this last one here that can be the tricky question: chronic hypertension with superimposed preeclampsia. So this is going to be chronic hypertension, which is again someone who has hypertension before 20 weeks gestation, chronic hypertension plus one of the following: new onset proteinuria after 20 weeks gestation, sudden worsening of hypertension, or signs of end organ damage, right? So this actually becomes very difficult to actually figure out, because if you look at it, if someone is supposed to have hypertension before 20 weeks gestation and they have signs of end organ damage, then you can definitely differentiate that from someone who has hypertension after 20 weeks gestation and has end organ damage, right? So the main thing is this 20 weeks period, right? Chronic hypertension with superimposed anything has to have the chronic hypertension first, and chronic hypertension is before 20 weeks gestation, and then other things may get added on after 20 weeks gestation. That's the superimposed part because it got added on, right? So that's the only unique one. I haven't found a question on this topic, but definitely something I would imagine Steph would ask you about. Down here, you're called to the nursery to evaluate a newborn infant. The mother is a 24-year-old primigravida. Her pregnancy was complicated by preeclampsia, so the infant was delivered at 39 weeks gestation via cesarean delivery due to maternal hypertension and non-reassuring fetal heart tones. So they probably noticed that from the non-stress test they did. On exam, the infant's weight is 5 pounds. Okay, so it's not huge, placing him in the 5th percentile. Height is 18 inches, which is also very small. So growth didn't occur very well at all because of probably the early delivery and the hypertension. And head circumference is 13 inches, which thankfully isn't so bad, 10th percentile. The infant's head seems large for his body size because the body is small. There is a paucity of subcutaneous fat. The remainder of the physical exam is fine. This infant is at risk for developing what complication? The answer here was polycythemia. 50% of you picked it, while others chose these other answer choices: hip subluxation, hyperglycemia, hypercalcemia, or hyperthermia. I didn't really understand like hyperthermia just because there's a little bit of subcutaneous fat. Babies are full of fat. That's kind of all they have. They don't have any real muscle per se, right? It's all fat padding to keep them warm. So hyperthermia didn't really make any sense to me whatsoever. I didn't really know where people got hypercalcemia as an answer choice for either. Hyperglycemia, remember that hyperglycemia after being born was not the answer, right? It's always hyperglycemia as a fetus because the mom is hyperglycemic, but as a neonate after being born, the baby is usually hypoglycemic, especially if the baby was born to a diabetic mom who caused the baby to have excess insulin. So the insulin made the baby even more hypoglycemic. So hyperglycemia is never a logical answer choice for a newborn unless the question is literally telling you things that make sense for some reason. Right? And then hip subluxation would occur if the baby was too big. Then during delivery, the hip subluxation could occur, but that's not the case here. The baby's not big. So even by cancellation of topics, even if you didn't really know polycythemia is the answer, you could get to it. Infants are labeled small for gestational age when their birth weight is below the 10th percentile, as in our guy. These low birth weight infants usually have intrauterine growth restriction, which can be symmetrical or asymmetrical. Infants who are small for gestational age are at risk for several complications, as in the table above. So this thing right here, and also, what was the other thing? Anything else? Okay. So mainly just hypertensive disorders, things that can occur. Right, so polycythemia. So where was I? The infant table. Polycythemia results from increased EPO in response to fetal hypoxia, right? Which is something that you can, of course, physiologically understand. Anytime a baby's not getting enough blood and air, blood and oxygen, the baby's going to make more hypoxia occur. And with hypertension, that is a thing, because hypertension means your blood vessels are constricted, so not enough blood will be coming to the baby, not enough blood coming to the fetus, so the fetus then starts trying to make EPO. Hypoglycemia is more likely due to low glycogen stores, not hyperglycemia. This is just the explanation for the other answer choices. Decreased subcutaneous fat also impairs their thermoregulation, leading to hypothermia, not hyperthermia. Right? A baby could be born with lesser fat just because the baby is small in size, so hypothermia might occur. But a baby will almost never have hyperthermia. No matter how much fat the baby is born with, the baby is going to be really nice and comfortable. The decreased transfer of calcium across the placenta usually leads to hypocalcemia, not hypercalcemia. And hip subluxation is seen in large babies, not little ones, right? So that's the breakdown for being able to cancel out other answer choices, even if you didn't know polycythemia was the answer. But it was because of literally the things I've underlined. The mom had preeclampsia and hypertension, so the baby had fetal hypoxia because of constricted blood vessels not bringing enough oxygen and blood, so the baby made more EPO and got polycythemia. That's it. Right here we have another one which was related to treatment. 38-year-old woman comes to, so again over 35, comes to the office to discuss management of hypertension. She has chronic hypertension, which is managed with a stable dose of chlorthalidone. She is nulligravid, but is currently planning pregnancy within the next year. So this automatically falls into a wonderful mom, right? Because she's coming in before she's getting pregnant. She's making sure she's checking everything and making sure she's ready. It is a very common scenario for obstetric doctors to get really upset with their patients, because as an obstetric doctor, the last thing you want to see is a baby being born weird, being born abnormal, being born with some kind of malformation because the mom became or mom acted in a very selfish manner and did something stupid. So this is the kind of patient you'll like as a physician that's in obstetrics. And then there's going to be patients like the other one who had never seen a doctor that you're not going to be very happy about, because they're obviously being very irresponsible, and it is your duty to actually show them that they're being irresponsible. But in STEP, you don't do that, right? So in STEP, you treat everyone like you're talking to literally someone who we fabricate. Like, for example, we often say, oh, why are you acting like Trump? Where you can't really point fingers at someone, because if you try pointing fingers at Trump, he would just point it back at you and tell you that didn't happen, right? So that kind of stuff. You have to treat everyone here in the physician ethical department of questions as if you're talking to a king. You got to be very careful. You can't say anything that's even remotely offensive. You can't really point fingers at them. You can't really say anything like, oh, you're being so irresponsible. In the real world, you'll do it, but not on STEP. Right? So be very careful with that. She's a lifetime non-smoker, doesn't drink, so all that's great. Her mom was diagnosed with hypertension at age 35. Blood pressure is okay. Right? BMI is all right too. Physical exam is fine. No end organ renal damage. Potassium 3.7, so that's also normal. Hemoglobin A1C, kind of sort of pre-diabetic, but not the worst case scenario. What is the best advice to her? So now, there were two answer choices that were both kind of sort of legitimate. If we were to pose this question to 1,000 active doctors right now, I'm sure we would still get the same percentages of 50 to 30%. 50% of people said switch to extended release nifedipine, and 30% of people said just continue current therapy because she's doing okay. Right? If you really think about it, this is a type of question where you should be continuing current therapy. That's because she's asymptomatic, nothing's wrong, no issues. But there's something to watch out with her just because she's thinking of getting pregnant. If it wasn't a question about pregnancy, the answer would be continue current therapy. In pregnancy, chronic pre-existing hypertension is hypertension diagnosed prior to or during the first 20 weeks gestation, or persisting more than 12 weeks after delivery. Chronic hypertension confers an increased risk of maternal and fetal complications. First line therapy in non pregnant patients would be the thiazide diuretics, calcium channel blockers, and ACE inhibitors. However, some meds are contraindicated in pregnancy, so women who are planning pregnancy should change to safer meds. Extended release nifedipine is safe, while immediate release nifedipine may cause rapid drops in blood pressure, while other calcium channel blockers are not well studied, so they are not typically used. Other first line options are methyldopa and labetalol. She, right now, was taking chlorthalidone, which isn't exactly the worst thing, but I don't think they explained it here. Let me look it up real quick. Chlorthalidone, where is that in this? Thiazide. It should be in thiazide diuretics, right? Legal farm. Chlorthalidone. It's right here. And so decreased calcium excretion. Yeah, I don't really see how this was that bad. You know, like I remember because even after reading the explanation for that question, I still am not 100% sure why we would change her therapy, right? But apparently, starting the nifedipine was a better answer choice. What the question is working off of is literally this table itself, where first line includes nifedipine, but first line does not include chlorthalidone. Chlorthalidone would go in second line as a thiazide diuretic. But in the real world, which is why I say that 50, this 50-30 ratio would be there with 1,000 doctors, is in the real world you don't really change medications if it's working fine. The same concept of if it's working, why change it? But of course, with STEP and the understanding of exact um, nitty gritty picking on things like that, it's important to remember that list, which is why I always go back to that in step one, farm, cardiovascular farm, right? Labetalol, nifedipine, hydralazine, methyldopa. Those are the 4 key medications we really like using on a pregnant woman. And if it had to be in order, it would be in that order: labetalol, then nifedipine, then hydralazine, and last methyldopa. Methyldopa is a little slow; it's not very rapid onset. Um, Short onset of action is sometimes necessary, especially if it's hypertensive crisis. But yeah, not the chlorthalidone. So that's all this question was really about. Annoying question, but it gets the lesson into you, especially if you pick the wrong answer choice, then it sticks to you because you don't want to make that mistake again, right? So annoying, but yes, this question was just about what is first line and what is second line. And then after that, we have eclampsia and UTI, so we'll continue that tomorrow and move on to the next topic because this stuff is now just going to be a quick. Well, actually, I can wrap it up. I mean, eclampsia, there's nothing new. It's the same stuff, but just seizures occur now, so you have to give magnesium. And here you get questions where you want to make sure you don't give too much magnesium. So that's all eclampsia is. It's preeclampsia plus seizures. And UTIs is what we'll continue from next time because there's actually a lot more to know about than just this. I want to revisit something in step 1 and the antepartum hemorrhage, and we'll move on to obstetric complications of pregnancy. And I'll leave it right here for now because we'll start with these 2 questions next time.